those are two really important abstracts looking at dosing of niraparib because, when we think of oral agents, I think a lot of us clinicians as well as patients thought an oral agent, it's not going to have the same side effects or there's side effects we won't have to worry about like we did for chemotherapy, and that's not true. And niraparib's done a fantastic job of, going from phase 1 to phase 3, and it's a very exciting compound with how it's excreted by carboxylate esterates. It has high bioavailability, good tissue penetration. So to me, all that is very exciting to treat tumors. But at one point, you had to worry about the side effects, fatigue, nausea, vomiting, as well as thrombocytopenia. So looking at the weight-based dosing and looking at the criteria that they use to look at the patient's baseline weight as well as baseline platelets, and I have to be honest with you, I think when we use those criteria, about 70% of patients in our clinic are going to get dosed at that lower dose at about 200 q-day. That if you talked with the nurses, myself, the PAs, and the patients, that I think the number of side effects have decreased. The thrombocytopenia has decreased, the fatigue has decreased, some of the nausea has decreased. But in general, when we start somebody on PARPs in general and niraparib, niraparib will tell them take it at night. We'll give them prescriptions to help with diarrhea, prescriptions to help with constipation, as well as nausea and vomiting. I've heard some people trying to use just some baseline antiemetics for consistently for 2 months to not let the cycle develop. I typically haven't done that because I think taking it at night will help with that and then treat those patients as needed. I've used some low-dose steroid. I put a patient on low-dose steroids for like 2 weeks, and that really helped with her nausea, and she's been doing fine after that. So I think there's many different ways that we can try to tweak that. But what I would say is that starting at the lower dose, as we've seen the decrease in the side effects. It's hard to say, we want to make sure that everything stays as effective, and we haven't seen any patients that have seemed like they've had a rapid fall off with respect to recurrence or anything out of what we've seen within the literature, but it's definitely something that we need to pay attention because, again, the FDA dose is 300 down to 200. There are many drugs, I would have to say, that we use in GYN oncology that the FDA dose may be higher than what's the typical dose that we use when we treat patients. But to me, niraparib using the weight-based dose, the individualized dose, I think, I wait the FDA's review of that to see if they're going to approve that. But I think in clinical practice, so phase 4 data, us using the drug in clinical practice, it has definitely bore out and was definitely very helpful. So, the abstracts by I think it was Dr. Monk and Dr. Madalonis, I think were very important to help us manage these patients. We have a lot of interesting single-agent compounds that we're now starting to do the combinations. And again, I mentioned Tapasio. So I think that's the tip of the iceberg that we're going to do many of these types of combination therapies. I also think that the amount of molecular data that we're going to need to interpret when we see these patients is going to become more complex. But I also think that we're in the era of 5% medicine, which means we may have to send off 20 tests to find one test that we can make a significant change in therapy that may make a significant change in outcome. So I think that the next 5 years are going to be very exciting, just like these past 5 years. We have other drugs. Hopefully, I'll be coming out some antibody drug conjugates. Again, combinations of many of these therapies. The first trial, which is combination, Avastin, dostarlimab, as well as niraparib, an upfront setting for maintenance therapy, I think is going to be a very important trial because we talked about BRCA, we talked about HRD. Unfortunately, most patients are HRD negative, and that's where we're struggling right now with upfront treatment. So as we can come up with better combinations, and I do think that combination immunotherapy with PARP inhibition is going to be very, very important. So I look forward to the dostarlimab data with niraparib. And again, there's other trials being done out there that are going to be looking at that from Clovis as well as AstraZeneca. So all these companies, I think, are benefiting our patients with the rapid drug development and development of these combinations, which is a huge change compared to 10 years ago. I mean, we have so many clinical trials available for patients. The change is rapid, which is excellent for them.